I think scam is not a term that I would use. I can hear why people would feel that way.
Hello, team, and welcome to Bureaucracy. I'm your host, Emily Gross, and I'm very excited today because I have Dr. Linda Blumberg with me, who is a research professor at Georgetown at the Center on Health Insurance Reforms and also an Institute Fellow at the Urban Institute. Linda, thank you so much for being here.
Thanks for inviting me.
So we are going to be talking about health insurance in America, very relevant conversation. Before we even begin, murder is bad. No one is condoning murder, right? That is something that I feel everyone baseline can agree on, right?
Absolutely.
So obviously this conversation's following, the murder of the UnitedHealthcare CEO, and no one should be murdered, right? And we're also allowed to have a conversation about the frustrations of the American healthcare system. And so that's what this podcast is going to do, So anyways, Linda, thank you for being here.
My pleasure.
I always love to ask my guests, why should we trust what you have to say?
Well, I think that probably my experience as a health economist for over 30 years and researching across that time, everything from healthcare financing, healthcare reform, and a lot of time spent studying private insurance markets and private health insurance in the United States. So I've done a great deal of research and policy analysis in all of those areas.
Yeah, wonderful. Excited to get into the conversation. And what are we drinking today?
Well, those who know me best know that my drink of choice is not beer. It is gin, but I wanted to stick with your theme. And so my in-house consultant has brought me a Bell's special double cream stout, which sounded like a good mocha espresso flavored winter choice for me. So that's what
That sounds really good. As I always say, we do not shame any drink of choice. So, if we do this again, feel free to bring the gin. We're
excellent.
Good.
Then we'll break out the no-lets next time.
Perfect. And I have Bronx Brewery World Gone Hazy IPA. Cheers.
Excellent. Cheers.
All right. I think it kind of begs the question of a lot of the commentary online had to deal with people talking about their claims being denied and needing health care coverage and not receiving payment for it and it being denied by massive health insurance companies. How is that allowed? And what are the regulations by the federal government of massive health insurance private companies?
Well, first of all, we have to recognize that the regulation of health insurance, both at the federal level and the state level, changed tremendously in 2014, which was the year when the full implementation of the Affordable Care Act occurred. Before that, first of all, there was very little regulation of private health insurance at the federal level. It was largely done at the state level. And the laws were really had lots of holes. There was lots of ways in which private insurance companies were able to deny coverage to people outright, to end their coverage based on evidence that they were going to be high users of medical care. There was lots of exclusions for pre-existing conditions or conditions that the insurer thought the person should have known that they had, even if they were never diagnosed with that before they enrolled. So there was no real rules about what had to be covered in an insurance plan, and there was no financial assistance to speak of for private health insurance for people who didn't have access to coverage through their employers and who were of low or modest income. So lots and lots of gaping holes in private insurance prior to 2014. Okay, the Affordable Care Act brought a sea change in regulation, lots of improved regulation, a federal floor. While there was still some variation that has been allowed at the state level, the federal government really came in with a floor and said, we've got to set these rules in place to make these markets work better for consumers, to make the coverage more meaningful, more valuable, and more affordable. So, I just want to make it clear that there's been huge amounts of progress in private insurance markets under the Affordable Care Act since 2014. However, there are still problems and issues. So one of the things that the Affordable Care Act did was to say, listen, you can't exclude people's pre-existing conditions. You can't, issue them policies that don't cover, anything that you think might be expensive. No more policies that say we don't cover chemotherapy, right? Which we saw before. No more policies where
absolutely crazy.
It was crazy, right?
Crazy.
And people didn't know there was no English language version of the policies. So people were buying policies not even knowing what was covered until they went out and tried to use it in many cases, right? Or most of the premium, 50, 60% of the premium could have been going for administrative costs, right? And very few dollars from the premium were going towards paying claims. So all of that changed. However, as the federal government and the state governments rightly started closing these gaps in what private health insurance would do and cover, what the private insurers did was respond by trying to find other ways to hold down their own costs, right? When their costs are lower, they're able to charge lower premiums. They can be more competitive in the market. And so what they were doing was saying, okay, well, we can't deny people outright anymore. We can't dump them after finding out that they, had some serious medical expenses. We can't not cover most of the expenses that people are going to need. But what can we still do? Well, one of the things they can still do is deny claims, right? Now, part of the Affordable Care Act, at least for the private non-group insurance market, where people were supposed to be able to where people are able to buy coverage outside of an employer setting, the Affordable Care Act said, listen, on these marketplaces where these policies are going to be sold, we're going to make the insurers report how often they decline, what their rate of declining claims is, so that people can compare when they're consuming. That actually has never been implemented. Okay, so it's a gap, but it's also an issue not just in the non-group insurance market, but in the employer market, right? So people have United, they have Cigna, they have, other private health insurance. Maybe they have a self-employed plan, a self-insured plan from their employer. And the claims still, sometimes it's appropriate to deny claims, right? A claim comes in, it's not appropriate. It wasn't medically necessary. The insurer shouldn't have to pay for it. However, what studies have shown, for example, from the Kaiser Family Foundation a couple of years back, those researchers showed that the rate of declining claims varies enormously across insurers. From, like the Kaiser Permanente has a declining rate of something like 7%, and some others are approximating 50% of the claims that come in, right? So the variation is enormous, and there's really no regulation of that. And the insurers, people are seeing newspaper articles about high rates of declining claims at United and Cigna using AI, et cetera, to, quickly go through at very little expense and just decline. And then people are, when they can, they're shying away from those plans. But there's really no good oversight at state or federal levels for the declining of claims. And it's one of the ways in which insurers are continuing to try to lower their own costs.
Wow. I mean, I'm employed, thankfully, knock on wood, but I'm only offered UHC plans, right?
Mm-hmm.
So it's absolutely wild that we really have no general overall public healthcare system that anyone can qualify for. And all these private insurance companies are being like, you're going to pay money to us because you need health insurance, because if you have outright medical bills, you're going to be screwed. Right?
Right.
And we can still deny you. We can still deny your claim,
And there are processes to go through for appealing those denials when they occur. But most people who have a claim denied don't go through the appeals process. And the insurers know that, right?
They make it difficult.
And they make it difficult. And it takes time, right? And a lot of people who don't have as flexible of employment as some of the rest of us don't have the time to get on the phone, to get the rules for appealing the denial. often you've got to get your provider, your physician involved or the hospital involved in helping you respond to a denial and trying to get it back through and get the claim reheard and get it ultimately paid. And it's time consuming, and the insurers don't want you to go through this process, right? So they're not going to make it straightforward and clear about how to do that. And that first round, at least, of appeals process, you're going back to the insurer that just declined your claim, right? And trying to appeal it through them. If they decline it again, your recourse is to go to the Department of Insurance in your state and try to get them engaged in an appeals process that's external to the insurer. But this takes a lot of time. It takes a lot of energy and fortitude on the part of the consumer. And while if I'm, continuing to appeal a claims denial from a hospital, for example, that could be pretty sizable, they may, while it's taking all this time for me to go through that process, they may be sending, my bill to collections, and I'm getting threatening phone calls that are saying, if we're going to ruin your credit rating if you don't pay this bill, et cetera, et cetera. So it really is a challenging process for a lot of consumers to go through.
Yeah, I've had this is inspiring me to continue my fight with Cigna, because I had to pay out of pocket for something, even though it was covered in health insurance. And they've asked me 3 different times to change the claim, right? They're like, we need this information. No, we need this information. No, we need this information. And then because they're no longer my health insurance company, they basically logged me out of the platform. And so I couldn't access it. So it's like, understand fully the amount of steps that people have to go through. 1, I'm able to take the time to do it. And 2, I'm really fucking stubborn. So I'm going to go after that.
Yeah, no, rage helps a lot. And the knowledge that you're in the right. And, and it is very difficult. I mean, I've gone through this for family members, for friends, and talked to colleagues who go through all kinds of pain and suffering in order to get their claims paid. And, and that's with people who have a good deal of knowledge and education, and they have the flexibility to be on the telephone in the middle of the day, right? Not everybody has that because of the constraints of their workplaces.
So what kind of conversations are happening at the federal level surrounding health insurance? Like healthcare for all, public healthcare system has been one of the biggest conversations, I feel like, in American politics. And what people want versus what's being discussed, I think is very different. But, you're in this world. What's being talked about?
Well, I think there are a lot of remaining challenges in our private health insurance system. There's the issue of claims and the rates of denial, but that also goes part and parcel with the prices that are being charged for healthcare services, right? And so we have a situation here where we've got a system where there has been in the last 15, 20 years, a tremendous amount of consolidation, both on the side of the health insurers, right? We've got growing health insurers like United, biggest private health insurer in the country. They're not just a huge insurance conglomerate that has both data services, and they do administrative services for self-insuring plans. They have their fully insured plans in all markets, but they are also now the biggest employer of physicians in the country. Okay, so there's been both horizontal integration and there's been vertical integration. And it's not just with these big insurers. It's also who are buying up providers, but it's also provider systems, big hospitals that have merged with other hospitals that are buying physician practices and outpatient practices, right? And you've got a huge influx of the participation and kind of the takeover of private equity buying up big healthcare provider systems, right? And so the greater, you go back to your Econ 101, and what happens when you have kind of situations that are in some markets becoming monopolies on the provider side or the insurer side, or both, or maybe they're duopolies, right? But what happens is that you get a situation where the prices are higher and the supply is constrained, right? And so we have these situations where, for example, you go into a metropolitan area and it could be that there is one owner of all of the radiology practices in that particular area, or private equity has bought up basically all of the anesthesiology practices. And there's quite a bit of research evidence that when that happens, the prices that are being charged by those practices increase. Okay. As hospitals are buying up these outpatient entities, they're increasing the prices through various different mechanisms. We have no regulation of prices in the private insurance space, only in public coverage like Medicare and Medicaid is there regulation of the prices that are charged for different services. And so when you've got all this market power being concentrated in a very small number of entities, you've got that on the provider side, and sometimes you've got it on the insurer side. Sometimes you've got it both in the same places. And so you've got the insurers, trying to get the prices down, but they can't get the prices down because of all of the consolidation on the provider side. And so that's driving up the prices that the insurers have to charge. They have no leverage over the providers. The providers are getting more and more concentrated because that's the only way that they can fight against the concentrated insurers, right? And it becomes this battle of these behemoths that leads to higher prices for the consumers, and a lack of ability of the insurers, even if they wanted to bargain those prices down. And so they're trying to figure out, well, the only way I can, hold down prices and make my product somewhat more attractive to consumers is by figuring out how to lower my claims cost, right? And so that's where, they're coming in with denials and things like that. So we've really got a situation that has gotten out of hand on both the provider side and the purchaser side. And so thinking about ways to get the prices under control and to also regulate the behavior of the insurers to make sure appropriate claims are being paid is really, where we need to go from where we are now. But it's, you think about what the political process is for doing that, and you're talking about huge money and political interests on the side of all of these entities. And then there's other private entities that are making money to help these behemoths, fight with each other, right? And so they're coming in with new technology to manage the claims on the provider side to make sure that the providers are getting the money that they're owed and that they're getting the right prices. And then the insurers are hiring other entities that are creating processes and software and intermediaries to fight back the providers. And it's just like this churning of private money that's making a lot of money for a lot of companies, and consumers are left in the lurch.
Where is the pharmaceutical industry in this? I know this is a little bit out of your wheelhouse, but I do pharmaceutical and insurance are so intertwined. What's their relationship and how do they interact?
I am not, as you know, I think not an expert on the prescription drug industry. But the way that I think about prescription drugs is that they're one of the providers, right? They're one of the entities that are involved in providing services, medical services to the consumers. So the way that they operate and who they operate with as their intermediaries, and the prices that are set for their product, for the prescription drugs, feeds directly into the cost of insurance, right? And so if we have no rhyme or reason in the pricing process for prescription drugs, and it's basically what, the market will bear and what the insurers are willing to pay, then that's just going to continue to drive up the prices as well. So when you look at some of the reforms under the Biden administration to put limits on the Medicare side on a subset of the most expensive prescription drugs, the idea is, bringing the strength, the market purchasing power of the federal government to bear and say, listen, we've got to hold down these prices to hold down the costs of our public insurance programs. But that has not yet moved over into the private markets and the non-elderly, and how much they're having to pay for prescription drugs and how much the insurers are having to reimburse for prescription drugs.
Do you know off the top of your head the average amount people pay for health insurance?
Well, I could look. I think that the average plan in are you talking about on the employer side or in the non-group market?
Well, that's also
prices are
crazy
gonna
to
be
me too,
different.
is the fact that like, listen, like employment is good. It's good for people to be working and contributing, right? Whatever. But you're also then it's like, I mean, there's a period where I was unemployed and I was looking at my health insurance options. It's like, okay, well, I'm getting unemployment, but I'm also then paying $1,200 a month for health insurance. And you're like,
Right.
how does this line up? How does this make sense?
Right.
You know, it's crazy.
Yeah. Well, and the employers are paying a good deal of the cost of the coverage on top of what you're paying, right? So when you see what you're paying, what you're contributing, for your insurance through your employer, and to know that you're on average, across the country, that is, about, 20%, 25% of the cost of the health insurance policy, you realize that your employer is spending, a lot as well. So yeah, it's and then so we also have the situation of the splitting of these markets. So what an employer is paying on average is different than what an individual purchaser is paying when they go, for example, to a marketplace in their state and they pay for coverage themselves. And one of the things that we have found is that on the non-group side for individual purchasers, that a very strong determinant of the price that they're going to pay for health insurance is twofold, and that is the number of insurers that are participating, that are selling coverage in their particular area, and what the provider market looks like. So if you've got a lack of competition in the provider market and a lack of competition in the insurance market, you're going to end up having considerably higher prices than in markets where you have a decent amount of competition, both on the provider side and on the insurer side. But for example, the Medical Expenditure Panel Survey, which is a employer survey of employer health insurance plans, they have for single coverage in 2022, which is the most recent year of their data, they have an average employer premium, that's both what the individual pays and what the employer pays, was about $7,600, and that was 2 years ago. So higher than that now. And for a family policy, their average was about $22,000 a year. So getting to be very expensive. On the non-group side, it tends to be a little bit lower, but it varies tremendous amount geographically.
It's crazy. It's crazy to me how it costs so much money, and then that's just like the basis to have it, and then you have to pay on top of that for
Right.
care you receive. I mean,
right, deductibles and co-payments and co-insurance
right.
and all that.
It's crazy. I had a medication that was $60 to $70 with insurance. And I went to the doctor. It's like, is there anything else cheaper? And he's like, no, sorry. Everything else is like the same tier 3, So I'm kind of surprised there hasn't really been, have there been antitrust lawsuits?
There have been antitrust lawsuits. It is extremely challenging for the Department of Justice to win those. They have had some successes, but they've had a lot of losses. And, the problem when people say, listen, we've got these really high prices in medical care, and everybody knows there's been tremendous consolidation in the hospital system and across physicians, et cetera. we should solve this by better enforcement of antitrust. My response is, well, better enforcement of antitrust is good going forward, but there's already been so much consolidation in these systems across the country that the cat is out of the bag, right? We can't fix the consolidation that's already there by greater antitrust enforcement for mergers and acquisitions that are going to happen in the future. The only way we're going to address the problem for what has already happened, you could break apart some of these large entities. That would be incredibly challenging to do, I think. I'm not a lawyer, but I think that's very unusual to be able to do. But you can regulate how much these providers are charging for particular services. So we can look at data and see that, some doctors, some hospitals for certain services in certain areas are being paid something like, 600% sometimes or more of what Medicare pays for the same exact service, right? So, and you can say, listen, there's variation and, various different things, and we've got to have enough dollars in the system to keep our, providers in business, and there's issues in rural areas, et cetera. And I get the complexity, but I also don't think that any provider needs to be paid 600% of what Medicare is paying for the elderly for that same service you're providing to the non-elderly, right? There's got to be some limits on what providers pay for a service, not just what their market leverage allows them to charge, so that somebody in an area where private equity or whoever has bought up all the anesthesiology practices can be charging, 6, 7, 8 times as much as what that same kind of physician is being paid in another area for the same service. That just doesn't make rational sense. It's not competitive. It's anti-competitive. We're not going to be able to make these markets competitive in the way you theoretically would want to, as in the pure way economists think about competition. So it's time for us to set some caps, some limits on what these prices are going to be in a way that takes into account the resources required to provide the service.
Right. And I know doctors are also very frustrated with insurance companies as well.
They are. In a lot of ways, that's why it's attractive for them to be bought up by private equity and other large companies and other large, hospital systems, because then they don't have to deal with the negotiations and the billing. Somebody else does. Somebody else sets the prices and interacts with the insurers for them, and it takes them out, and they don't feel like they can get the prices that they want on their own, but these big behemoths can, because if they own everything in the area, then they've got all of the leverage and the power to get the prices that they want. But so what we've gotten down to is nothing near competition. What we've got is, in a growing way in lots of places in the country, we've got huge corporate behemoths fighting each other about what to pay for, how much to pay for it. And they're battling with each other and not at all necessarily in the interests of the patients.
It's a world that I feel like is so relevant to everyone's well-being in day-to-day life, yet is clouded in so much, mystery and back channels and something that is just so secretive to the everyday life of America, like an Americans.
Well, and there's reason for that, right? These big systems, the big hospital systems, et cetera, they don't want us, they don't want the researchers even, or the policymakers, to understand these billing processes. When you start getting into the nitty gritty of how these services are billed and the source of the pricing and all of the information in the detail, it becomes so incredibly complicated. And the providers will say, billing is really complicated and you don't understand it. And so you can't regulate it and you can't try to regulate it. And it does, you start to recognize, both as a policymaker and a researcher even, just how much you don't know, because the billing is incredibly complex. But it's done that way on purpose.
Yeah.
And they don't want to make it transparent. They don't want to make it clear. And so, I mean, listen, we're in a situation where a lot of insurers, and I'm not excusing the insurers and their behavior in terms of these high rates of declining claims. But, a lot of insurers, the private insurers, don't even know, where a service is being provided, right? Because if you've got a big hospital system that owns multiple hospitals and outpatient clinics and physician practices, they are often all billing the insurer under a single ID that is associated with the hospital. So the insurer doesn't know if that mammogram or whatever service you got or doctor visit, if it was performed in the hospital, in an outpatient clinic, if it was in a physician office. So if they wanted to say, listen, I'm going to only pay for this service in this particular location, and I'm going to pay the same amount, regardless of where the service is being provided to try to lower costs. They don't even have the information to know where it was provided. So, so if you are, and this is a strong incentive for the hospitals to buy up practices, because what they're doing now in a lot of places is hospital will buy up a medical practice, and that medical practice, they now interpret that as being a hospital outpatient department. So not only are they billing for the physician fee as that practice has always done, but now they're adding on a hospital bill for a facility payment, which is intended to cover overhead costs at the hospital. And so a patient might get a bill for a copayment for their doctor visit like they always did, and then they're going to get a bill for a hospital visit that they never actually had, because now their physician practice has been bought up by a hospital, and the hospital's calling that a hospital cost. So so they may have to pay towards their deductible or a co-insurance for a facility fee that the hospital is charging on top of the copayment that they're paying for the professional fee for the doctor. And it becomes so confusing to the patient and increases their costs. And it's also increasing the cost to the insurer. And the insurers are saying, well, what am I supposed to do? I can't not have this must-have hospital system in my network. And it's, the battle of, who's going to be covered and what the prices are. And it is a real problem.
It almost feels like medical providers and pharmaceutical industries are trying to scam insurance companies. Insurance companies are then trying to, it feels like insurance, pharmaceutical, and medical providers are all trying to scam each other and get the most money out of each other as possible.
I think scam is not a term that I would use. I can hear why people would feel that way. I'm not, but I would say what they're doing is they're maximizing profit, right? In the way that economists speak. And they're doing what they can. They're setting up systems and structures, and they're doing mergers and acquisitions in a way that is going to allow them to maximize their profit. And we have not ever decided in this country that we are going to stop the corporatization of medical care, right? We've got some insurance that's publicly provided, but we've got a lot of insurance that goes through private insurers, and we've never said that we're going to, regulate the prices on the commercial side, at least for what the providers can charge. And so we're in this situation of having made our health care system on all sides a commercial enterprise, and these entities are behaving as profit maximizing enterprises. They're doing what they're allowed to do. And it is a matter of whether or not we decide as a society that we've had enough and we're going to put some limits on it.
Absolutely. Well, that comes down to the question about the Affordable Care Act. One of the big conservative talking points is going to repeal the ACA. What would that look like? What would happen?
I mean, it's almost unconscionable at this point to repeal the entire ACA, because it is so inextricably entwined in every regard in our healthcare system now. It is about how Medicare pays. It is about how coverage for Medicaid. A very significant amount of that is tied to law under the expansions under the Affordable Care Act. The way that healthcare providers have set up systems and are dealing with their financial interests is all entwined with the health insurance coverage changes and the rules. Insurers have completely changed their rules of operation in terms of what they can charge and how that can vary, right? For example, one of the things that the Affordable Care Act said was that, at least in the small employer market and in the non-group insurance market, you can't charge people more based on a function of their health status or their health history, right? The premiums can't vary more than, 3 times for the oldest adult to the youngest adult. So it's basically, any way you can think about healthcare delivery in this country, it has been modified to some degree by the Affordable Care Act. We were in the neighborhood of 50 million people uninsured when the ACA was passed and growing, right? And now, we are at the lowest levels of uninsurance in the history of the country. So, huge numbers of people, if the Affordable Care Act were to be repealed, would become uninsured. That would have not just a huge effect on people's affordability and access to medical care when they need it, but it would also impact the financial well-being of every health insurer and private health insurer and every healthcare provider, doctor, hospital, clinic in the country. It would have, enormous and devastating impacts, and to say it would create chaos is really an understatement. And I'm not prone to over dramatize, policy changes, but it's almost like you can't really undo it at this point, unless you really want to throw the entire healthcare industry and everybody's access to care into a chaotic, uncertain situation.
From a legislative standpoint, what would have to be done to repeal it?
Well, I mean, there have been legislative efforts to repeal it in the past. Now, part of the issue, one of the things that we, with my Urban Institute colleagues and I analyzed at the beginning, it was actually right before the beginning of the last Trump administration, was that because you would need 60 votes in the Senate to overturn all of the pieces of the law, right, to really repeal the entire thing. Really what they could do with a majority, with, their simple majority votes, is to repeal it through the Reconciliation Act. But the Reconciliation Act is actually constraining in that it only allows you to repeal the pieces that directly affect and substantively affect the federal budget. Okay. So what you could do is you could get rid of all of the financial assistance that helps people afford health insurance coverage when they don't get it through their employer and their modest income. You could get rid of the Medicaid expansion, right? That is providing virtually free, very comprehensive coverage to very low income people, basically the poor people up to about 138% of the federal poverty level in all of the states that have been, the vast majority of states that have taken it on. What you couldn't do through that, though, is undo all the insurance regulations that say you can't exclude pre-existing conditions, you can't deny people coverage based on their health status, et cetera. To change it, you couldn't change the rating rules. And so what that would mean is that you would suddenly have this market that is open to people regardless of their health status, but you wouldn't have all of the people, the healthy people, being brought in by the financial assistance that came with the Affordable Care Act. And so the only people that would then be looking at that coverage, because the average cost, once you take all these, healthier, low-income people out, the average cost of the coverage has gone up, right? Many fewer people can afford it, but the doors are still open to all the people with health problems, right? Well, who's going to really scrape together all the money to buy coverage that is, accessible to them, but with no financial assistance. It's people who know they've got a lot of expenses that have to be covered, right? And so the average expense, the average medical need of the people who remain in that market goes up. And then the insurance premiums go up. And then the more of the healthier people leave. And you've got this situation where basically you're throwing the private insurance market for, in this non-group market in particular, into a situation that's worse than it was before the Affordable Care Act was put in place, because now you've kind of, it's all become, high medical need people with a lot of health problems, and you're essentially collapsing that market. So it really, you end up with more people uninsured when you start picking the pieces off that you can through the reconciliation process than what you had prior to the law being reformed. It becomes a big, terrible mess, honestly.
Interesting. No, it's interesting how it's also appears to be not in the insurance company's best interest to have it repealed either, which is not discussed, which I feel like is an important conversation to be having as well.
Absolutely. But I think the, a very significant danger is that what may happen is, kind of a picking away, as we saw in the last Trump administration, kind of an undermining of the law without completely eliminating it. Things like, so they basically got rid of all of the outreach and enrollment assistance that, that was going on to help people know in various different, states across the country that this help was there and that they could get it. So that kind of knowledge of what was available was taken away, all the finances for that. And there was encouraging of these the navigators and the people that were working for the marketplaces to suggest to people that they go buy coverage that is not protected by all of the Affordable Care Act rules. So these kind of short-term limited duration policies, which are like the bad old days of health status rating and no good coverage and dumping you when you got sick, et cetera. Having, federally funded assisters encouraging people to go to those really not good, those really bad, kind of trashy policies. So I think encouraging people to go, to buy higher and higher out-of-pocket cost policies so that when they got sick, they couldn't really access the care that they needed. So there's lots of ways in which the administration can undermine the consumer protections in the law without eradicating the law completely.
Interesting. Disappointing.
Yeah, I mean, it's very concerning, for those of us who worry about consumers and for those of us who worry most about people who have significant health problems, right? It's one thing when, you're, 20 something and you really don't have much medical need, right? And you would like to have a less expensive policy and you're not so worried about the network, et cetera. And then, unfortunately, lightning strikes, right? And so suddenly you've got an autoimmune condition that requires really expensive drugs, or you get, hit by a bus or something happens or you have a pregnancy, et cetera. There's lots of different ways in which, the medical expenses jump out at you as a surprise. And when you don't have these consumer protections in place and you don't have coverage that's high value and comprehensive, you are really in an incredibly vulnerable place. And of course, as you get older, that vulnerability just increases.
Well, before we wrap up, as people who are on health insurance, what's one thing we can keep in mind if we're fighting with health insurance companies, and trying to get claims?
So I think the first thing that I suggest to people is make sure you get a detailed itemized bill. Oftentimes, especially with hospitals, what you get in terms of a bill is a summary. It doesn't have the detail. And so if you're going to identify something on that bill that is inappropriate, a service that you didn't get, for example, or that you think the severity of what your situation was in an emergency room has been overstated, the only way you're going to be able to see that is by getting a really detailed bill from the from the hospital. And so always ask for a detailed bill. Sometimes it takes an annoying amount of time and requests to get it. But that is really important. When there is an issue on the bill, make sure you're talking to the insurer and the provider, and letting them know that you see this problem. Sometimes the insurer can actually behave as an intermediary to help in that kind of situation. But there are appeals processes, and sometimes it takes, I've been on the phone with administrative people at hospitals where I'm looking at the coverage for the person in front of me, and I know that they've been charged 10 times what they were supposed to be charged for an emergency room visit. And the person on the phone is saying, no, they have a deductible. And I'm like, no, I'm looking at the plan right now, and there is no deductible. It's a $200 copayment. They're like, no, there's a deductible. And I just keep going back and forth and saying, no, you're wrong. You need to look at this. I'm looking at it. And after 3 times, they'll be like, oh yeah, you're right. And so when you look at the summary of benefits and coverage, it should that every insurer has by law under the Affordable Care Act has to give to you that is in plain language what you're supposed to pay, and stick with it and interact as often as you have to with the provider and the insurer. And then there is an appeals process through the Department of Insurance if you're not getting satisfaction from the insurer. But if it's a problem from the provider, often the insurer's interest is to help you to figure that out. If the problem is with the insurer, you ultimately may need to go to the Department of Insurance with a complaint.
This conversation is the first time I've ever heard of the Department of Insurance.
Every state has one, and there are consumer representatives that are there to help you if you have a complaint to file with a private insurer that's licensed in your state. I will tell you some of these really garbagey policies, and the policies that were of interest to some of the allies of the last Trump administration, to have these policies that could be sold across state lines and, yada, yada, yada. Those policies, you're going to have a lot more trouble with the Department of Insurance helping you if, some of those things are allowed in the future. But really try to buy policies if you're on your own. Make sure your policies are being bought through the policies that are rated as appropriate and acceptable under the Affordable Care Act. And going through the marketplaces in your state is a good way to do that. But yeah, there are appeals processes both within the insurers and within your state, should you need them.
Great. Linda, this was very helpful. Thank you so much for providing insight and
sure.
Just emphasizing the fact of how important it is that there are regulations.
Absolutely. And to know your policy, always ask for a summary of benefits and coverage so that you know the details of your policy and what should be covered.
Absolutely. Thank you. I'm your host, Emily Gross. We'll be back next week with another episode of Bureaucracy.